Before I introduce our first speaker, Dr. Sunderland, today really couldn't be possible without our support, without the sponsors that we have that you'll see on the back of the schedule here. And we have educational partners. We have Men's Health Network. We have NorCal Carcinet, Women Heart, and Zero. And then our industry partners, Advanced Accelerator Applications, Blue Earth Diagnostics, ITM, and Progenics Pharmaceuticals. And I want to thank everybody for all the work and the participation and their help in putting together this 8th Patient Education Day. So let's talk about Dr. Sunderland. University of Iowa, serves as the director of the university's PET Imaging Center, director of Small Animal Imaging Core, and associate professor of radiation oncology in the Division of Nuclear Medicine, associate professor of physics and astronomy. He is also the vice chair of SNMMI's Clinical Trials Network. I'd like to introduce Dr. Sunderland.
Thanks a lot. Now I'm upset I got rid of my second slide before I did, which had the 6 pillars upon which the SNMMI is based, and one of them is patient education, patient advocacy. So this is an important part of what the society does. So my charge is actually just to do a very basic overview of nuclear medicine, molecular imaging, kind of how it works and what it does. I've broken it up into four parts, just one slide on the difference between anatomical imaging and molecular and nuclear medicine, just to try and differentiate that from the get-go. And then we'll talk about 15 minutes on what nuclear medicine is and how it works, kind of from a technical standpoint. You'll forgive me, I'm a physicist by training, and so I have to do a little bit of that on the front end. And then what is it used for? We use it for diagnostics, and we're using it more and more in the therapeutic arena, and so we'll get into that, both what's approved and what's come by FDA and what's coming down the road, and then a little bit on radiation safety considerations as we are, in fact, dealing with radiation. So just starting on the front end here, what you see in the upper left-hand corner, on the left-hand side are some anatomical imaging techniques. You're familiar probably with most of them. MRI in the top left, that's functionally imaging hydrogen or water density. It gives you great soft tissue contrast, beautiful anatomic images. There's a great diagnostic CT down there which shows a nodule, which you can't really tell whether it's cancer or not, but you can see that little dot down there. You can see because of the pattern emphysema, and what makes this particularly diagnostic is in the upper right-hand corner is the cigarette pack that's sitting there, which helps the cancer diagnosis. Angiography by injecting dye in the veins. You can actually, in the artery, the vein, it also goes to the arteries, you can actually look at the arterial blood supply to the heart. You can look for, because of anatomy, you can look for stenoses and blockages there. Ultrasound isn't just used for obstetrics, it's used in cardiology, it's used in oncology, and all of these are great, and they have their uses, but they're all fundamentally looking at anatomy. Whereas in the molecular imaging, nuclear imaging biz, we're largely looking at the biochemistry of the body. The anatomy is largely incidental. What you see on the left of that slide is one of our FDG scans, fluorodeoxyglucose. And here what we're doing is we're imaging glucose metabolism. Because there's glucose metabolism all over the body, you can kind of see the anatomy, but that's secondary to the fact that we're imaging glucose metabolism. You can see the uptake in the brain because we're thinking. You can see the uptake in the heart because it's a muscle and it's pumping and they're using glucose for fuel. But you can also see the tumor in the lung, which would just be a nodule on a CT. Malignant, not malignant, don't know, but because of the high uptake, we can actually pretty confidently describe that as a malignant tumor. You can see the kidney actually recognizes the radioactive glucose we injected as an imposter, so the kidney's actually filtered out, and it goes down to the bladder, which you kind of see down there. That's normal physiologic uptake. What you see in the upper right is a DAT scan. This is a SPECT scan, where you inject something that goes into the presynaptic dopaminergic system. They use this for differential diagnosis of Parkinson's disease from other motion disorders. And in the lower right-hand corner, you see some cardiac perfusion scans that look at blood flow to the heart to look for people who have cardiovascular disease. These are just examples, but in all of these cases, we're looking at the function, not so much the anatomy, which is a big difference. So, with that out of the way, we're going to get into how nuclear medicine works. So why is it called nuclear medicine? Where does the nuclear come from? Well, in all cases in a nuclear medicine study, we're administering, usually injecting, but not exclusively, a tiny quantity of drug. And so in this case, here's a molecule. This is one of those sugar molecules. This is fluorodeoxyglucose. And right there, that's the F-18. That's the radioactive tag. So my kids have one of these. It's called a cell phone. And they go around all over the country, and I can track where they are because I follow where that phone is on my phone. Similarly, that radioactive thing that's sitting there, that's what we track, and that's what we image. We don't image the molecule. We image that radioactive nuclear, in this case, fluorine-18 that's sitting there. Now, when I say we're injecting a tiny amount, I mean we're injecting a tiny amount. That image that you saw of glucose metabolism, about 1/1,000,000th of a single grain of sugar. That's the mass quantity of the drug. Okay? The good news is there's almost no side effects from the drug. There is radiation, we have to worry about that. But the drug, if I took 1/1,000,000th of an Advil, the headache that I have right now, it wouldn't hit it at all, right? So we're at sub-pharmacologic doses here. But then what we use is when that radioactive fluorine decays, what we do is we get gamma rays. And the gamma rays that come from the nucleus radioactively decaying, which we'll talk about in a minute, that's what we detect, and that's how we get our images. Okay? We're going to talk about it in much more grisly detail in a moment. So you're probably all familiar with the periodic table here, right? And so what we do in the nuclear medicine biz is we use what Mother Nature gave to us. So we have these elements, right? And you've all seen this, but I always consider the periodic table as a shallow two-dimensional representation of a three-dimensional space. So if you actually look at carbon 6, which is, you can kind of see it going back there. Carbon has 6 protons, right? That's by definition what carbon is. And most of the carbon in our body is actually carbon-12 because it has 6 protons and 6 neutrons. It's stable. That's what we have in our body. Mostly. There's some carbon-13. 6 protons because it's carbon, and 7 neutrons, which is 13. That's stable, but only a small fraction of that, right? But the good news, at least for us in the biz, is there's also carbon-14 that has 6 protons and 8 neutrons. That has too many neutrons for the nucleus's own good. It's unstable. It wants to get stable again, and it does this by radioactive decay. This has a half-life of about 6,000 years. We don't like to use it in people with a 6,000 year half-life, but this is what you use for carbon dating, right? Mother Nature gave this to us. We have this. We can actually, and we end up using it for carbon dating. We can go the other way with carbon-11. This actually has 6 protons and 5 neutrons. It has too many protons for its own good. It ends up being unstable, and it decays by positron decay. It's actually so unstable, it has a half-life of about 20 minutes. But what we do in the nuclear medicine biz is we can take that carbon and we can attach it to a molecule whose physiology we want to trace, like in this case choline, right? We inject in, choline is an FDA-approved tracer to image prostate cancer, and it's a little bit hard for me to point to, but kind of in the lower left quadrant there's a lymph node down there that's actually positive for disease, and on a CT, I mean, we have lymph nodes everywhere. You see this lymph node. It's a lymph node. It's the right size for lymph node, along with all the other ones. It's not diagnostic, but that one has cancer, and that helps them guide radiation therapy or surgery or something like that down the road. So it's the C11, but what's really important is the radiopharmaceutical there. Just another real quick science slide. The nice thing about radioactivity is, frankly, there's only 3 kinds we have to worry about. If there's too many neutrons in the nucleus, which is on the left, it decays by beta decay. That means it emits an electron from the nucleus, which only goes about 1 millimeter. If we have too many protons in the nucleus, that's the middle one, it decays by positron decay. And when a positron gets emitted, so a positron is an electron, except it's positively charged. It's an antimatter electron. It's a real live it means antimatter. And what it does is it goes that same millimeter or so until it stops. But when it stops, it usually runs into an electron because there are electrons everywhere. And when they get close to one another, they annihilate. That whole mass can neither be created nor destroyed thing, right? So that's wrong. The electron has mass, the positron has mass, but after they meet, they annihilate. They're gone. But in their place, you get two gamma rays, energy that are going off in opposite directions, back to back. That's what we detect when we do a PET scan. And that energy you get, that's the E equals mc squared thing, right? The m is mass, the E is energy. And then on the right side that we don't use so much for imaging, but we use for therapy, we have alpha decay, where the nucleus emits this very massive, it's like instead of emitting a ping pong ball, it's emitting a bowling ball. And that ends up being important when we talk about therapy a little bit. From an imaging standpoint, what's important is with the alphas and with the betas, and frankly with the positrons as well, see, we can't detect the beta particle. It's only going like a millimeter. It's going to stop in the body. Same thing with the positron. But usually what happens is after it emits that beta particle, the nucleus is in an excited state and it goes to the ground state. When it does that, it emits a gamma ray. The gamma ray is a high energy electromagnetic radiation, and it can go through the body. And this is what we're detecting. When that nucleus decays by whatever it does, it emits this gamma ray, and the gamma ray can go through the body, and we can detect it with our scanners. This is my tribute to Bob Ross. Most of you who know Bob, even my kids know Bob Ross. He's kind of a superstar now, even for them. So we use these radionuclides that are available to us kind of as our palette. We like to choose the ones that fit our needs for imaging or therapy. This is just a list of 10. There's probably about 60 or 70 useful radionuclides out there. Some of them have short half-lives, like the imaging ones. We'd like to inject the short-lived ones for imaging, because then they'll just go away. By the next day, they're pretty much gone. For the therapeutic, which is kind of up at the top, if we're going to inject therapeutic radionuclides, we'd like to have them sit there bombarding the tumors for a really long time. We'll get into that. So having a longer half-life is a good thing. And the kind of decay, all these things enter into it. We have to get very clever about how we use them. But it's not just the radionuclide, it's not just the half-life. Really, it's all about the molecules we attach them to. This is just 3 of several hundred that are out there. Most of them are on the research phase. Some of them are FDA approved and we use clinically. Here's 3 that are out there that all kind of represent different things. There's that glucose one again that has fluorine-18, has a half-life of about 2 hours, decays by positron decay. Actually, all of these are positron emitters. The one that's in the middle is florbetapir, which we use for Alzheimer's disease. What's interesting about this is it does a great job of attaching to the amyloid in the brain for Alzheimer's disease, and it's FDA approved, and CMS doesn't reimburse for it. And then on the right-hand side, we have gallium-68 DOTATATE, which is very much like NetSpot, for those of you who are familiar with it, which is approved. Gallium-68 DOTATATE is not yet approved, although we at the University of Iowa have submitted a new drug application, and hopefully we're about 2 weeks away from approval for that. So fingers crossed on that. Yes?
What CMS is?
Oh, I'm sorry. When I say CMS, I mean Medicare, right? So Medicare has chosen not to pay for those Alzheimer's because we don't really have a treatment for it, right? So they say, oh, you diagnosed it, so what? That's their point. I don't necessarily. So bottom line here is, so what we do is we have these radionuclides that are attached to these radiopharmaceuticals. We inject them into patients, and then we have to image them. So if they're positron emitters, we use the PET scanner. That's designed to get both those, so we have a ring of detectors. It's designed to get both those gamma rays off at the detected at the same time. If they just emit that single gamma ray, then we use the SPECT scanner, which is down below. And so that's usually the beta emitters we use SPECT scans for. And the standard planar gamma camera images, we generally use the same SPECT scanner, which is down below. The procedure is pretty simple. In general, we administer the radiopharmaceutical 95% of the time it's by injection, but we do have other modes of administration. So I'm going to show you this. This is some friends of mine worked with a company in China, and they built a PET scanner that's 2 meters long, so you can get the whole patient in there at the same time. And this is one of the very first images that they, let me see if I can get my, very first images, they injected FDG in the leg, and this is 1 second images. You can see it going up the leg, into the lungs, into the brain. We're about 45 seconds in. It's beginning to distribute into the heart, into the liver, etc. And now it's kind of going 2 minutes. You can see it going into the brain as it's being metabolized. You can see the kidney has actually filtered out and the bladder's filling up. You can see all this over time. First time we've ever been able to see what an injection does all at once, let alone what FDG does. So we can get full pharmacokinetics of all of these things now with this new device. PET scanner, but 2 meters long. Very cool. Bottom line is we do inject this stuff. There's an uptake period. That uptake period could be anywhere from a few minutes to maybe an hour or two. When you put them in the scan typically takes 15 to 30 minutes. Actually, these days with new scanners, it's usually down to 10 to 20 in order to get a whole body scan. So that's how we do it. Now the question is, how do we get the images? Just a couple of really quick slides here. Once again, we have our glucose molecule that actually has the unstable nucleus. When it decays, once again, we have that positron that goes off in about a millimeter. We get the annihilation, and then we have those rings of detectors which actually try and detect both those photons at the same time. At the same time means within about 5 billionths of a second of one another. We can actually kind of trace back to where the event occurred because 2 points define a straight line. We don't just detect one of these, we detect tens of millions of these events, and from that we can reconstruct these images. So in PET, we're looking at 2 photons at once. In SPECT, so this is DAT scan. This is the one that looks for Parkinson's disease. It has iodine 123, which has a bit of a longer half-life. But when it emits that beta particle, but then the important thing is it emits that single gamma. There's 2 detectors, one on the top and one on the bottom. It detects if it's going up or going down. We actually detect it, and those detectors actually rotate around the patient over time. It goes about a half revolution, and from that we can reconstruct what the distribution is in the brain, or really wherever, or the heart, or whatever it is we're looking. And that's as much as I'm going to go into how those scanners work. I just want to repeat again that nuclear medicine is always tracer methodology. The quantities, the mass quantities that we inject are really, really small. For the most part, although FDA doesn't like us to say it, there's really no side effects associated with these quote-unquote drugs because the mass quantity is so small. That doesn't mean we don't have to worry about the radiation dose. It doesn't mean you don't have to worry about, there might be, you might get a bruise at the injection site. But the drug itself, the mass is so small, we really don't worry about that too much. And FDA realize, they make us check it, but they realize that these are really low-risk drugs from that standpoint. It's not like you're giving a therapeutic drug for these diagnostic. The mass is really small. Okay. So now that's how this all works. Let's go to some of the applications. I'm going to talk about the diagnostic ones first, the current ones, and then some of the unapproved ones that are coming down the pike. Each of them, this is by no means an exhaustive list. It's just a sampling. I think I go through about 10 or so, and then I'm going to go through a couple of therapeutic applications and then on into safety. So all of these slides coming up right now have the same format. You've seen the FDG ones. I'm not going to go into too much detail here, but I am going to go with the format. So in the upper left-hand corner is the molecular structure. I know you can't see it very well, and frankly, I don't care. What I want you to realize is they're just all different. So whatever the application is, the molecule has to be tuned to the physiology that we want to trace. I have the modality, whether it's PET or SPECT or standard nuclear medicine. I kind of have an example, what it's used for, what its availability is, and the regulatory and reimbursement situation. And then almost most important is the localization mechanism, why it does what we think it does. So this, we've talked about fluorodeoxyglucose. It's used for a wide array of solid cancers, solid tumors, but is not used very often, at least, for prostate cancer or neuroendocrine tumors. Those are relatively indolent. They don't usually grow very fast. And as a result, the glucose uptake, they don't require a whole lot of energy, so they don't show up very well. So we have to be a little discriminating how we use it. It turns out that most cancers use glucose like crazy, which is why they light up like little Christmas lights kind of all over the place, because they've actually got something wrong with their metabolism that makes them burn glucose. It's approved. It's available just about everywhere in the USA. This is NetSpot. Gallium-68 DOTATATE. It's a much more complicated molecule. Gallium-68 has a half-life of about an hour. It's used specifically for neuroendocrine tumors. Why is that? Because neuroendocrine tumors overexpress somatostatin receptors commonly found there, and so they've been clever enough to define a drug, a molecule that seeks this out and binds to it and actually sticks and pretty much won't let go. Okay, and that's what this NetSpot, this gallium-68 DOTATATE does. It is approved. It is reimbursed, although you have to get pre-approval by insurance companies. It is not quite ubiquitous as far as availability is concerned, and I think this is a modification of something from Josh's website, where he has the sites where this is produced. His doesn't have little circles. I have little circles that define about a 1 hour radius around these, because it only has a half-life of about an hour, and you don't make much of it when you do a synthesis. So these are the places you have to be kind of within one of those circles in order to get this, because it's not widely distributed. Okay, but the good news it is available. Okay, so on to prostate cancer. So I got a couple of, so I showed choline before, that's one approved agent. Another approved agent is F18FACBC, which has the trade name Axumin. It's for prostate cancer. This is an amino acid, and it targets a transporter that is overexpressed in prostate cancer. And here you can see in this image the little dot there in the pelvis, which is where it's spread to, which is very helpful for the physician to either do surgery or radiation therapy to make sure he targets it. This one I made a point of showing the CT background on those color ones, right? So sometimes the PET scans are so specific you can't see the background anatomy, so the surgeon doesn't know where to go because there's no landmarks. So most PET scanners, really all PET scanners these days, you can get a CT done at the same time, so you have the anatomical backdrop in which to project the PET scan so you know exactly where you're looking. This, once again, is available just about all over the country because it's transportable. You can go, on the order of 3 hours outside. The reimbursement situation is good, but pre-approval is required. Cardiac perfusion. So I have two examples here, both PET and SPECT. They do pretty much the same thing. Perfusion means how much blood is going to different parts of the heart. The left ventricle is the important one here. This is what pumps it all the way through. That's the big muscular part of the heart. And it's kind of shaped like a bullet. And so where you see those round donuts, that's like looking at cross sections of the bullet. And what you like to see is like what you see, the SNMMI SPECT scan on the right, the rubidium on the left, the rubidium on the right. And what you like to see is that nice round donut there. The ones below it that look like this is a vertical slice through it. The one on the bottom is a horizontal slice. Once again, those are normal. Not normal is what you see down below. The apex is the tip of the bullet, and you can see under rest conditions at the tip, it's pretty much thinned out. That means there's probably a stenosis, not a whole lot of blood getting there. And under stress conditions, they get on a treadmill and they inject it, you can see there's almost no blood getting there because the stenosis is so much. When people have angina, they have pain, heart pain when they exercise. This is what's happening. That heart muscle is not getting the perfusion. They can see the extent of it and the impact of stress on it with these cardiac perfusion. I mentioned this brain imaging before. Drug companies were all hot on this because they found a way to image the amyloid. 3 companies went as far as to get these approved. None of these are reimbursed. All of them are approved. They are available. They're being used extensively in clinical trials, largely to look at treatment drugs, because they like to know whether somebody actually has Alzheimer's disease or not before they actually try the drugs. This is an example of kind of how it works. I should go back and say the ones on the right, I'm sorry, on the left, is what normal uptake is. That's white matter uptake. But when you start developing amyloid plaques on the cortex, which is the outside of the brain, that's what you see on the right-hand side. They look a little bit different, but in all cases you see that the amyloid spreading to the outside. Where this ends up being important is in a series like this. These are 4 different patients. The one on the left is normal. The 2 middle ones are the important ones. MCI stands for mild cognitive impairment. That means you're a little bit forgetful. You forget what you said 5 or 10 minutes ago. But there's a lot of causes for that, and it could be early on. These 2 middle patients have the same symptoms. One of them doesn't have Alzheimer's disease. The other one does. And you can see the mild cognitive impairment amyloid burden is pretty much the same as full-fledged Alzheimer's disease. That's the AD on the far right. So differentiating it is actually pretty important, but CMS and the Medicare people don't seem to think it's that important yet. I only do this one. This is a bread and butter nuclear medicine scan. This is actually not SPECT. This is just plainer. I bring this up because I mentioned different kinds of administration. So the ventilation scan is done with xenon-133, which is radioactive gas. You inhale this. So that's what you see on the left-hand side. That's just to see where the air is actually getting in the lungs, because sometimes those are not normal. What you see on the right, they use this for identifying pulmonary embolisms. Those should be kind of uniform lung, kind of black on either side. This is actually looking at where the blood goes, because it's not just where the air goes. The air has to go through and get into the blood. Where you see those inhomogeneities, where it's light in there, that's where the blood's not getting where it's supposed to. This is a standard nuclear medicine scan done with two different drugs, one xenon, one technetium-99 labeled. I mentioned and showed this Parkinson's disease one, this DAT scan. This is an approved agent, iodine-123. It's SPECT. And this is taken up and stored in the vesicles of presynaptic brain cells, which are generally sitting in the caudate and the putamen, which is those comma-shaped things on the left. That's normal. The putamen the cells begin to die, and then in Parkinson's disease. And so you can see on the right-hand side, the tails have kind of gone away, and that's a telltale sign that the patient actually does have Parkinson's. You can also see it's a little asymmetric. And so you can see one is a little bit more diseased than the other. Okay, that's just some basic approved ones. Here's some not FDA approved but coming. This is another exciting prostate cancer agent, gallium-68 PSMA. There's a lot of excitement over this. The choline is good, the axumin is good, but the PSMA seems to be able to detect much smaller lymph nodes sooner. At least that's what the literature is looking like. There is a phase 3 study that was completed between the University of California at San Francisco and UCLA. They are literally a couple of weeks away from submitting their new drug application. We hope that they get this in. Approval is likely, but not certainly, because that's up to FDA. Within about a year. Widespread availability would be maybe 3 years or so. That's because not everybody can do it. If we want to do it in Iowa, we would have to submit an ANDA. That's a whole other application, and that goes to the Office of Generic Drugs, and it takes them about 2 years to approve those. So it'll be available likely nearby. We can go the expanded access IND route, but we'll just have to see on that. But it's got to get approved first. But it's quite exciting. It's a good agent. Frankly, it's likely a stopgap solution because there is another F18 labeled PSMA, this F18 DCFPYL, which is in phase 3 clinical trials right now. This does pretty much the same thing as the gallium-68 PSMA, but you can make a lot more of it, and with a 2-hour half-life, you can distribute it a lot further. So for widespread public availability, this, if I look into my crystal ball, will likely be what most places use 2 to 3 years down the road, assuming the phase 3 clinical trial is successful, assuming they submit the NDA, and assuming FDA accepts it. So, but that's very exciting area as well. That first one, the gallium, is academically sponsored. The PYL compound is industry. And the neuroendocrine space is not static at all. There's this OPS 202, which is for neuroendocrine tumors. It works a lot like NetSpot. It works a lot like DOTATATE, except it's an antagonist, which at least it's hypothesized it has some advantages, both from an imaging and a therapy standpoint. It too is not approved yet. It's just phase 2, and that's really just starting, so it's a bit away. I want to move on to therapeutic applications just for a couple minutes. And to this, we need to begin to understand a little bit about radiation, and not just what it can do for us, but the harmful effects. And I'm going to get into the doses here in a minute. But we do know that very large doses of radiation can kill cells, or at the very least damage the DNA so they don't go on. But if a human gets very large doses of radiation all at once, and 500,000 millirem, and we'll talk about what a millirem is in a couple minutes, it can cause acute harm and even death. We know this from Hiroshima and Nagasaki, these kinds of things that's been studied extensively. So we know that radiation is dangerous, particularly in very large doses. However, we can use these toxic effects of radiation to our advantage. If very large doses of beams of radiation are aimed very specifically and carefully at tumors, the cancer cells, we can selectively treat the cancer. Now, this is not molecular imaging or nuclear imaging right now. I'm just kind of going outside of this to show what external beam radiation therapy does. Here we have a CT scan of somebody going through their lungs, and you kind of can see circled, there's a tumor there. And what you do in radiation therapy is you shoot a beam of radiation, which is sublethal from one direction, right? And it goes on through, still a lot of radiation. But then you do it from another angle, and then they overlap. And where they overlap, you now have twice that dose. And you do it from another angle, and so what you do is you get a lot of dose to the tumor, and you get less to the outside. And that's targeting the radiation to the tumor, but not exclusively. You're still irradiating kind of everything else outside of it. Wouldn't it be nice if you could just get the radiation just to the tumor and not this other stuff? So that's what targeted radionuclide therapy is all about. And those of you who are in PRRT and some of these prostate cancer trials, it all seems quite new. It's really quite old. In fact, Saul Hertz back in 1936 had the idea to treat thyroid cancer with radioactive iodine. And he treated his first patient in 1941. You can actually ingest it. So we talked about inhaling, we talked about injections. You can actually take a pill that has radioactive iodine 131, goes in the system, and the body just moves it to the thyroid and pretty much nowhere else. And you can obliterate the thyroid and, more importantly, the thyroid cancer. Tens of thousands of people have been treated with this over the years. So this targeted radionuclide therapy is not new. But what's happening now is we're using it a lot more specifically because of three things. One is we're getting better and better at characterizing at a molecular level the different kinds of cancer, the kinds of chemicals that are specifically on the surface of melanoma or on the surface of prostate cancer, and we target drugs to this. Then we're getting really good at designing custom drugs that will go specifically to those targets. And then lastly, and sometimes this is the hardest step, then we actually have to take those drugs, but we have to attach the radioactive atom to it so we can actually so we can actually follow it. But we're getting very good at these things. And so we're doing it for neuroendocrine tumors, we're doing it for prostate cancer, those are pretty far along. But there are a lot of companies who are developing things for non-small cell lung cancer, for melanoma, for all these cancers. And keep watching this space because it's a very exciting arena. Not just for you guys, but for companies, because this is a very lucrative thing. And let me go back and just say, the good news about these things, it goes really specifically to the tumors, right? You don't have all this kind of crosstalk. It does go to other organs and all, but not nearly so much. So the more targeted you can be, the better off you are. And so this is just an example. This is with a NetSpot scan where somebody has tumor pretty much everywhere. And wouldn't it be nice, and this is just with the gallium, right? Short half-life. So the idea here is we take that same DOTATATE, that's the chemical that binds to the somatostatin receptors. You take that same, but you, instead of attaching this gallium-68, you attach lutetium-177. It has a half-life of about a week. So you inject it into the patient. Now it gives off a gamma ray so we can image it. That's why you have an image, right? And we didn't just inject a little. We injected a lot. We injected about 100 times more. It's 100 times more, and it's got a half-life which is 100 times as long. So it's like little machine guns shooting the tumors for weeks until it decays away because it stays bound. And so if you can do that and it happens to be successful, and there's no other way to treat this, right? And you go through, and in some cases, and I caution you, in the literature, they always show you the really good ones, right? So not very often do you have kind of complete responses like this, but it can be pretty dramatic sometimes, right? And so this is the promise. This is what we're looking for. Just so that you know, so the imaging part is the diagnostic. The therapeutic part, the targeted radionuclide, is the therapeutic. And so you might hear the word theranostics. The thera is for the therapy, what we do for the lutetium. The gnostic is the diagnostic that we do with the gallium in this case. And the therapeutic part is just targeted radionuclide therapy. The good news is we have a recent approval, lutetium-177 DOTATATE, Lutathera. It was approved. Just once again, here's another good example of here's a patient who has a lot of cancer. You treat them, and afterwards the cancer largely goes away. This is not necessarily a cure. This reduces the tumor burden and hopefully substantially. But it's remarkable, and you keep on doing this over time, and you can add a lot to it. This is results from the trial. A lot of you have probably seen this. The green line is the people, it's progression-free survival. That doesn't mean the cancer goes away. It just means it's not getting any worse, right? And so the green line is people who have received the Lutathera, and the gray line is people who just kind of had the standard treatment, which is not really much treatment at all. And you can see that, after 2 years, almost all of the minimally treated people had progressed, but about 60% of the people who had been treated, their cancer hadn't gotten any worse, and in some cases gotten better. So it's pretty dramatic. You don't usually see plots like this with treatments. If you look at these other chemotherapy drugs, they're not anywhere near as good as this. So this is what's kind of quite exciting. They're doing the same thing with this with the lutetium PSMA. Now this one's in clinical trials, so this is not approved, right? This was the image of the year, I think, last year at the SNMMI annual meeting. This was from a group, groups down in Australia. These are 6 different cases. And on the left-hand side, in all cases, is the before treatment, and on the right is the after treatment. They have artificially kind of shaded where the tumor is in red, so you can more easily see the before and after. In some cases, complete response. In other cases, dramatic responses. Once again, this shows great promise. As I said, this is in phase 3 trials right now, and hopefully at least the accrual will be done probably within about a year. They have follow-up for a couple of years to look at survival benefit and all. And so hopefully in a few years we'll have some good news on this front, but it's very promising. Now, I mentioned alpha particles at the very beginning, shooting bowling balls and stuff. And also I've been showing these great responses here. This is a PSMA. This is a prostate cancer patient with horrible metastatic disease. They tried the lutetium-177 PSMA, and it didn't get any better. In fact, it got worse. And if you look at the PSA levels down here, down at the bottom, you can see it actually gets worse. But what they did was they took the same PSMA molecule that targets the surface, and they attached actinium-225, which is an alpha emitter. And they gave the patient this 2 times, and they did respond, and they responded dramatically. And you can see after a third, the cancer is almost completely gone, at least visually here, right? So there's a lot of enthusiasm about alphas. Now you got to be careful about alphas because we don't really fully understand the dosimetry. As I mentioned, you're kind of shooting this bowling ball, so you really have to worry about toxicity issues with this kind of thing. And we're really just in the beginning phases, but there's a lot of enthusiasm here. Remember, we're years out from doing this clinically, but there's a lot of excitement in this area and a lot of work. Just a few minutes on radiation safety. and we are dealing with radioactivity here. A lot of times in literature you'll see the unit millisievert. For purposes of this talk, I want to use the millirem. It's not the standard unit, but I like it because we get about 1 millirem, which is from background radiation. We get about 1 millirem of radiation dose per day. So that's an easy thing to just kind of remember in the back of my mind. So by walking around, we got 1 millirem. Okay? Where do we get it from? We get it from cosmic rays. We get it from radioactivity of the Earth. There's naturally occurring radioactivity in our body. And about half of it we get from radon that we breathe that's kind of in the basement of our homes, usually. About 1 millirem per day. So that's what we all get just kind of as a background. I mentioned before we get large doses of radiation that can be toxic to us, and kill us. We do know, and that's at the 500,000, so that's 500,000 times we get in a day. If you get that all at once, you got about a 50% chance that that's going to kill you. Okay? We know that if we go down about a factor of 10 to 50,000 millirems all at once, that's the threshold at which we can start to detect maybe we get a few more cancers than we otherwise would. Okay? That's where the data actually shows, yeah, we really don't want to go there. So, and none of the diagnostic tests want to be in a place where we can be there. Most of the tests are way below that, and I'll show you some data on that. We do conservatively assume, and although there's little evidence, that even a small amount of radiation dose is bad for you. We don't know that a small amount of radiation is bad for you, but we conservatively assume that that is the case. That's all diagnostic radiology and nuclear medicine is based upon that. So it's prudent for public safety to assume that even small doses of radiation are bad for you, but there's no real good evidence for that, frankly. So also benchmark, I as a radiation worker, I can get 5,000 millirem per year, and I'm within bounds. That's because we have never seen any ill effects of radiation at 5,000 millirem per year. So we're in this safety zone, okay? And our technologists who treat, they don't get quite up to the limit, but they're on the order of 1,000 or 2,000 annually that they get in administering these patients their drugs. So on the left-hand side, everyday dose. Now, I flew out here. I got 5 millirem because so the atmosphere does a good job of filtering out cosmic rays. I get about 5 millirem just flying out here from the East Coast or the middle. So I get 5 times background. The 310 millirem per year is the average exposure. 365 days in a year, that's where I got the about 1 per day. Okay? And there's the 5,000 per year. Now, if we look in the right-hand side, we have the standard medical imaging radiation doses. So chest X-ray, do we have pneumonia or not? About 10 millirem. It's about 10 days of background radiation. Not that big a deal. Remember, a technologist can get on the order of 5,000 per year and not worry about it, right? If we go down to the nuclear medicine stuff, most standard nuclear medicine, about 200 to 400 millirem. That's about a year's worth you get in that. And for a PET CT study, you're between 1,000, let's say 2,000, which is still below what our technologists get, right? And the bottom line is for all of these, you're getting it done for a reason, right? So in the medical imaging biz, this is risk-benefit, risk-benefit. And so I don't put a lot of stock in these, but this is for perspective's sake, and hopefully this will be put up on the website. And you have to take some of this with a grain of salt. But if you look at the life expectancy effect of things like living in poverty, you're talking about 10 years of your life. If you look statistically, that if you're 30 pounds overweight, that's a 3-year effect. Radiation workers down at that 5,000 millirem, statistically, we don't know this, maybe 25 days, but you're getting down, 2 cups of coffee, and I'm way more than that. That's what I guess I need to worry about. And we have the lifetime fatal risk from everyday activity. Anyway, these are all here. And what they estimate for like PET scans or bone scans or things like this, these are just worst case estimates. There's no firm evidence behind it. That's the problem with these things. They make it sound like we know. We don't know. We're linearly kind of projecting backwards from these high doses. So we don't know. How much radiation is too much radiation for a diagnostic test? The answer is any more than is necessary, right? Each imaging procedure takes a certain amount of radiation to perform it appropriately. Using too much leads to unnecessary radiation dose to the patient. Too little may not provide enough information. Each imaging procedure is optimized for the medical task at hand. And I'm going to go a little off script here, and so this is my personal opinion, it's nobody else's. When people in particular get PET scans, it's usually life-threatening conditions. You want the scan to be of diagnostic quality. If people start worrying too much about radiation dose, and I think the pendulum has kind of swung too much that way, you run the risk that somebody's going to say, oh, I want to spare you radiation dose, I'm only going to give you half the dose. But if the image quality isn't good because of it, and you don't get the proper diagnosis, that's way more harm than getting a little bit more radiation. So you really want the test, the test to be done right. So when you take a picture with your cell phone and it's kind of dark and all, you can go into Photoshop and you can try but if the information isn't there, the information isn't there. So you need the right exposure. And we work very hard to do that, but as far as I'm concerned, it's all about the image quality, right? And because you have, in general, life-threatening disease, you want to make sure you get it right. What is the image community doing? There's an Image Gently campaign for pediatric imaging. There's Image Wisely for dose optimization for adult imaging. The society takes this very seriously. We're tweaking. We're doing, I was looking, there are 6 or 7 dosimetry sessions tomorrow alone where scientists are looking into this, both from a therapeutic standpoint and diagnostic. So bottom line is SNMMI has a web page on this that takes you to these different programs, and I think they're doing a good job of kind of optimizing it for all of the different procedures that are out there. And I think with that, I'll stop. Thank you.